It's my great pleasure to introduce our next session moderators, Professors Jolanta Malyszko and Jolanta Kowalewska. Professor Jolanta Malyszko is the head of the Department of Nephrology, Dialysis and Internal Medicine at Medical University of Warsaw. She's a member of the New Kidney Disease Improving Global Outcomes Executive Committee. Our next session moderators, Professors Jolanta Malyszko and Jolanta Kowalewska. An associate professor in Université de Quebec at Trois-Rivières, Canada, and professor and chairman of Second Department of Nephrology at Medical University of Białystok.
Jolanta Kowalewska is my colleague from the Medical University of Warsaw. We studied together. After the graduation, Jolanta moved to the United States and became a nephropathologist there. She is now an associate professor in the Department of Pathology and Anatomy in Eastern Virginia Medical School, Norfolk. In previous years, she held a position of the associate professor in the departments of pathology in Seattle, in Białystok in Poland, and in Los Angeles. Please take a lead.
Good morning. It's still morning here in Virginia. Thank you, Agnieszka, for such a nice introduction and the opportunity to be part of such an informative meeting. Today, it is my great pleasure to introduce the next speaker, Dr. Virginie Royal. She's a renal pathologist and assistant professor of pathology and cellular biology at the University of Montreal. She's also a section chief of anatomical pathology at her institution, and she's a very active member of Renal Pathology Society. Dr. Royal's research interest is focused primarily on glomerular diseases and kidney diseases related to monoclonal gammopathies. Today, Dr. Royal is going to give us an update on monoclonal gammopathies of renal significance. Welcome, Virginie.
Good afternoon, everyone. I'm happy to be here to talk about renal pathology in MGRS. Before I start, I would like to thank Agnieszka for the kind invitation and also for the organization of this virtual meeting. So today I will start by giving you a little bit of background by reviewing the definition of MGRS and why this term was introduced. Then we will review the updated classification of MGRS-associated renal lesions. I will then describe some specific entities, and the remaining entities will be described by or covered by Maria Picken in the second part of this session. So without further ado, let's start with the definition of MGRS. So it is important to point out that MGRS is a hematologic condition, and that this hematologic condition is characterized by kidney damage that is due to a nephrotoxic monoclonal immunoglobulin. This hematologic condition is also characterized by the fact that it doesn't meet criteria for treatment based on the clonal burden alone. So why was MGRS, or why was this term introduced? As you may know, the spectrum of plasma cell dyscrasia defined by the International Myeloma Working Group includes MGUS, smoldering myeloma, and multiple myeloma. The diagnostic criteria for MGUS and smoldering myeloma are based on the percentage of bone marrow plasma cell and the measurements of the M-spike in the serum. The diagnostic criteria for multiple myeloma are having greater than 10% bone marrow plasma cell and having at least one myeloma defining event. So here are the myeloma defining event, including the CRAB criteria. In here we can see renal impairment is part of the CRAB criteria. And interestingly, the IMWG criteria suggests that patients with multiple myeloma should be treated, and that patients with smoldering myeloma and MGUS should be observed. It is important to realize that the renal impairment in the CRAB criteria is defined as severe renal impairment due to light chain cast nephropathy or suspected light chain cast nephropathy. And this excludes diseases such as MIDD and PGN-MID. So if we were to follow the recommendation from the IMWG, these patients with MIDD and PGN-MID would not be offered chemotherapy. However, most of the kidney lesions associated with monoclonal gammopathy do not meet the criteria for multiple myeloma. In fact, they are driven by a small, dangerous B-cell clone that produces low level of monoclonal immunoglobulin that is toxic for the kidney. And this is particularly true for diseases such as MIDD, type 1 and 2 cryoglobulinemic GN, PGN-MID, and immunotactoid GN, where the association with multiple myeloma is low. So again, if we were to follow the IMWG criteria, these patients would not receive chemotherapy. The concept of this small dangerous B-cell clone has been recognized for a certain number of years. According to this concept, renal injury is determined by the physicochemical characteristic of the monoclonal immunoglobulin rather than by the characteristic or the features of the clone itself, including the tumor burden. So recognizing this, the International Kidney and Monoclonal Gammopathy Research Group came up with this new concept of MGRS, which is again a hematologic condition that causes kidney disease, but that would not otherwise meet criteria for treatment based on the hematologic condition alone. So this new term now allows for the reclassification of MGUS and smoldering myeloma as MGRS when renal involvement is present due to a monoclonal immunoglobulin. And these entities that can be reclassified not only include MGUS and smoldering myeloma, but also lymphoproliferative disorders such as LLC and other low-grade lymphomas. And why is it so important to reclassify these entities? Well, multiple studies have now shown that patient survival in these entities is good in most patients, but that the renal survival is quite poor. Multiple studies have also shown that the renal response or the renal survival can be significantly improved by offering a clone-directed therapy. If untreated, these patients will progress to ESRD, and there is a very high rate of recurrence after renal transplantation. These diseases can be caused by different mechanisms, the most frequent being the deposition of the monoclonal immunoglobulin in the kidney with the activation of the classic complement pathway. Another mechanism is the indirect mechanism by the overactivation of the alternative complement pathway or cytokine activation. More rarely, kidney disease can be caused by the intracytoplasmic or intravascular precipitation of the monoclonal immunoglobulin in the form of crystals. And it's important to point out that more than one type of lesion can coexist and that more than one compartment can be affected by a combination of different patterns. So in light of these findings, the IKMG published in 2015 this classification of MGRS-associated renal lesions. This classification includes 9 entities that are categorized based on their ultrastructural appearance as non-organized and organized deposits. The entities in the organized deposits are further characterized as fibrillary, microtubular, and crystalline deposits. This classification was revised in 2019 and was published in Nature Review. Here you can see the updated classification. If we look closer at it, The general or the main categories remain the same, except for the addition here on the right of this new category called no monoclonal immunoglobulin deposits. If we go back to the entire figure, this new arm here now includes C3 glomerulopathy. C3 glomerulopathy was already present in the 2015 classification, but has now been moved to this new category. Thrombotic microangiopathy has received a provisional status, waiting for additional data to confirm the association. Other additions include the addition of type 2 cryoglobulinemic GN. Type 1 was already present. The addition of crystal globulin glomerulonephrititis and a new category called miscellaneous. So now we will focus on these entities. The remaining entities will be covered by Maria Picken. So let's move to this first entity, characterized by non-organized deposits, monoclonal immunoglobulin deposition disease, or MIDD, which is one of the most frequently occurring glomerular disease associated with MIDG. By definition, it is characterized by the deposition of non-organized monoclonal light and or heavy chains, mainly in the basement membrane. It's a systemic disease with a predominant renal involvement, which means that other organs can be affected, such as the heart. There are 3 subtypes: light chain dense deposit disease, light chain deposition disease, heavy chain deposition disease, and light and heavy chain deposition disease, LCDD being the most frequent. The classic morphologic features include nodular glomerulosclerosis, linear staining of the basement membrane by immunofluorescence with the involved immunoglobulin chain, and powdery electron-dense deposits along the basement membrane by electron microscopy. It represents up to a quarter of the monoclonal immunoglobulin related glomerular diseases, which makes it the second most frequent MIG-related glomerular disease, just after amyloidosis. The association with a underlying monoclonal immunoglobulin is very high, with close to 100% of the patients having at least an abnormal serum free light chain ratio. By light microscopy, most cases show this nodular glomerulosclerosis with diffuse mesangial expansion, forming nodules with this smudgy appearance that are PAS positive and silver stain negative. By immunofluorescence, there is a linear staining with the involved immunoglobulin chain. In the case of LCDD, kappa is the most frequently involved. In HCDD, it's IgG. The location of the deposits, well, they are by definition always present along the TBM, and they are very frequent along the GBM, the mesangium, and vessels. By electron microscopy, there are powdery granular electron dense deposit along the inner aspect of the GBM, as shown here. There can be thickening of the basement of the tubular basement membrane with the corresponding IF staining. EM shows granular staining along the outer aspect of the TBM. Interstitial, PAS positive interstitial deposits can be seen in a minority of patients. There can be also vascular deposits, as shown here, with these PAS positive deposits replacing or surrounding the myocytes. Now moving to this second entity with non-organized deposits, proliferative glomerulonephritis with monoclonal immunoglobulin deposits, or PGN-MID. Diagnostic criteria are the presence of monoclonal immunoglobulin deposits composed of a single Ig class with light chain restriction by IF, having a proliferative pattern by light microscopy, non-organized deposit by EM, and no evidence of cryoglobulinemia. Interestingly, only 20 to 30% of these patients will have a detectable monoclonal immunoglobulin in the serum or urine. The rate of detection is higher in patients having an IgG1 disease. Most of these patients will meet the criteria for MGRS, and overt malignancy is rare. By light microscopy, there will be a proliferative glomerulonephritis that can be an MPGN, diffuse endocapillary, mesengoproliferative, and sometimes combined proliferative patterns. A minority of patients presents with focal cellular crescent and membranous pattern. By immunofluorescence, there is staining for a single immunoglobulin class with light chain restriction. It most commonly or most frequently involves an IgG and more specifically IgG kappa. The staining is granular, mesangial, and along the capillary walls. When an IgG or a monoclonal IgG is involved, then the IgG subclasses should be performed to confirm the monoclonality of the deposits by showing staining for a single subclass, here IgG3. More generally speaking, IgG subclasses is very useful to confirm the monoclonality in all glomerular diseases that are associated with the deposition of a monoclonal IgG. By electron microscopy, immune-type electron-dense deposits are present, so without organization, in a subendothelial, mesangial, subepithelial, and/or intraluminal location. Recently, a new variant of PGN-MID has been described, which is the light chain-only PGN-MID. This variant, beside, let's say, the composition of the deposits, differ from the more classic PGN-MID by the fact that there is a higher rate of detectable MIG in the serum, a higher rate of detectable bone marrow plasma cell clone, and a higher association with multiple myeloma. Now moving to the entities with microtubular deposits, cryoglobulinemic GN type 1 and type 2. So cryoglobulinemic GN type 1 was already included in the 2015 classification, and now type 2 has been included because of its monoclonal component. Cryoglobulinemia is a systemic disease when symptomatic renal involvement is present in 20 to 30% of the cases. In cryoglobulinemic type 1 cryoglobulinemic GN, the deposits are composed of a single monoclonal IgG or IgM. It is associated with lymphoproliferative and plasma cell disorders, and it meets the criteria for MGRS in about 50% of the cases. In type 2 cryoglobulinemic GN, the deposits are composed of a monoclonal IgM directed against polyclonal IgGs. It is most commonly associated with IgM secreting lymphoproliferative disorders such as Waldenstrom microglobulinemia. By light microscopy, it is characterized by a proliferative glomerulonephritis. Helpful clues by light microscopy include intracapillary PES-positive pseudothrombi and predominantly monocytes in the glomeruli. Vasculitis can be present. By electron microscopy, in up to 50% of the patients, there are microtubular deposits that are found in a subendothelial and intraluminal location, and often admixed with more immune type deposits. By immunofluorescence, there is staining for a single immunoglobulin class with a light chain restriction, with a mesangial, capillary wall, and intraluminal location. In type 2 cryoglobulinemic GN, there is staining for the monoclonal components, so IgM kappa in this case, but also for the polyclonal component, IgG kappa and lambda, resulting in this polytypic appearance by immunofluorescence. And these cases are better characterized on the renal biopsy as mixed cryoglobulinemia, and the definitive diagnosis of type 2 cryoglobulinemia will be made by the characterization of the cryocryte by immunofixation. Now, the second entity with microtubular deposits is immunotactoid glomerulopathy. This is characterized by glomerular deposits that are uniformly composed of microtubules that are staining for immunoglobulins by immunofluorescence in the absence of cryoglobulinemia and lupus nephritis. It's important to point out that this is a kidney-limited disease without systemic involvement. It's a very rare disease representing 0.04% of native kidney biopsies. And the association with underlying hematology condition is fairly high, found in 66%, mostly composed of lymphoproliferative disorders. It's a heterogeneous disease by light microscopy. This case shows a MPGN pattern with mesangial expansion by these deposits that are PAS positive and silver stain negative. There could also be a diffuse endocapillary proliferative GN. There can also be some subendothelial deposits and intracapillary deposits, and sometimes a membranous pattern can also be observed. By immunofluorescence, there is staining that is often described as smudgy in the mesangium and along the capillary wall, with most commonly IgG with light chain restriction in most cases. By electron microscopy, the microtubular deposits are described as being longer than in cryo-GN. They can also be found in a subendothelial location and intracapillary location, but also in the mesangium and also on the outer aspect of the GBM. Okay, now not all MGRS-associated diseases present with glomerular deposits of monoclonal immunoglobulins. So this is why this arm was added in the 2019 classification. And the entities included in this arm are those that cause disease by an indirect mechanism. And a good example of a glomerular disease associated with an MGRS-associated glomerular disease that has no monoclonal immunoglobulin in the glomeruli is C3 glomerulopathy. C3 glomerulopathy is further divided into C3 glomerulonephritis and the rare dense deposit disease based on the ultrastructural aspect. By definition, there should not be significant immunoglobulin deposition by immunofluorescence. And the inclusion of C3 glomerulopathy in the spectrum of MGRS-associated renal disease was based on the clinical association between a diagnosis of C3GP and the presence of a detectable monoclonal immunoglobulin. And in fact, up to 80% of the patients older than 50 years old receiving a diagnosis of C3 glomerulopathy will have a detectable monoclonal immunoglobulin. In those cases, the monoclonal immunoglobulin may act as an antibody to factor H. Other mechanisms have been proposed involving both monoclonal and polyclonal immunoglobulins. And an important caveat to keep in mind is that 15% of the cases of C3 glomerulopathy will in fact have masked monoclonal immunoglobulin deposits. This means that these deposits will not be seen or are not be seen using the regular frozen IF, but that will be revealed using paraffin IF. So this has led to the recommendation to perform paraffin IF in patients with C3 glomerulopathy and or a proliferative GN with a negative IF findings. Thrombotic microangiopathy has received a provisional status pending for additional data to confirm the association. Some small series and case reports have described an association between the diagnosis of TMA and the presence of a detectable monoclonal immunoglobulin. It is thought that the monoclonal immunoglobulin may trigger TMA lesions in the glomeruli by acting as an autoantibody against regulatory proteins of the alternative complement pathway. And in fact, the frequency of monoclonal gammopathy in adults patients receiving a diagnosis of TMA is 5 times higher than what would be expected in the general population. Another situation where we can see thrombotic microangiopathy associated with monoclonal gammopathy is in POEM syndrome. In POEM syndrome, the glomerular lesions are those of a chronic or subacute TMA with mesangiolisis, widening of the subendothelial zone. It is almost always associated with a monoclonal gammopathy of the lambda light chain type, and it is thought that the mechanism of injury is caused by a cytokine-mediated endothelial cell injury. Now, the last category, miscellaneous diseases, includes membranous nephropathy and atypical anti-GBM disease. This is the largest series published on membranous glomerulopathy with light chain restriction by Arcana Laboratory in 2017. They studied 28 cases of membranous nephropathy with light chain restriction. In 6 of those patients, there was an underlying proliferative disorder, and they were able to identify 3 features that were associated with the presence of a lymphoproliferative disorder, PLA2R negative, staining for only one IgG subclass, and the presence of focal proliferation in the glomeruli or crescents. As you may know, there is an atypical variant of anti-GBM disease that has been described. This variant is characterized by no or fewer crescents and has more endocapillary and mesangial hypercellularity. Anti-GBM is negative in the serum. There is a monotypic variant that has been described of this atypical form of anti-GBM disease, but the significance of this observation is still to be determined. So that leads us to my conclusion of this first part. What I would like you to remember is that MGRS is a hematologic condition that is mainly characterized by its renal manifestation, that MGRS-related renal diseases are determined by the physicochemical properties of the monoclonal immunoglobulin rather than by the characteristic of the clone, and that the spectrum of MGRS-related disease is wide and that it will probably continue to expand. Thank you very much.
Much for the first lecture. Okay. And dear moderators, can you please introduce the next speaker?
Okay. Good evening, good morning. Before I introduce the second speaker, may I express my sincere gratitude to be a part of this excellent symposium. And also it's a special time for me because I'm co-chairing this symposium with Jola Kowalewska. We have been working together for some time in Białystok, and we've learned a lot from her. We miss her very much. And just today, we have a pleasure to chair this particular session, and I would like to introduce Professor Maria Mrozowicz-Picken, graduate from Medical University of Gdańsk and fellow and resident in New York and now working in Chicago, to continue with a special, very interesting topic for hematologists, nephrologists, and pathologists on monoclonal gammopathy of renal significance. So, Maria, the floor is yours.
Hello, I am Maria Picken from Loyola University Chicago. I would like to thank the organizers for inviting me to speak today. I have nothing to disclose. You are familiar with this classification of MGRS-associated diseases. This is from the consensus report, which IKMG published about a year ago. And this is what I'm going to discuss. A group of conditions associated with fibrillar deposits, inclusions or crystalline deposits, and briefly interstitial nephritis-like pattern of kidney injury in the context of MGRS. In the group of conditions associated with fibrillar deposits, immunoglobulin-related amyloidosis is obviously a major player, but immunoglobulin-related amyloidosis actually belongs to a larger group of amyloidosis, which are protein folding disorders. It is a heterogeneous group of disorders. Deposits have, however, common features. Congo red affinity, they have a defined fibrillary structure, beta-pleated sheet conformation, and of course their deposition leads to organ damage. What happens during fibrillogenesis is illustrated here. In short, from globular and soluble proteins, there is a conformational shift to beta-pleated sheet secondary structure, depicted here as these flattened ribbons. And during this process, protein becomes hydrophobic, hence is insoluble, non-functional, resistant to degradation, sticky, aggregates, and also beta-pleated sheets provide the binding sites to Congo red stain. Now, some proteins are prone to misfolding, even in the wild form, due to their physicochemical properties, but the process of fibrillogenesis under normal circumstances is tightly controlled by the protein quality control system, which at the intracellular level includes proteasomes, extracellular macrophages, so they capture all those imperfect proteins, degrade, and return them into a metabolic pathway. However, when we have increased supply of such unstable precursors, or with aging the system is less effective, then we may have amyloidogenesis. Now, increased supply of unstable precursor, typically it will be associated with clonal plasma cell dyscrasia, chronic inflammation. We may have AA, amyloidosis. There is a group of hereditary amyloidosis where mutation renders affected protein less stable, and then some proteins, example being transthyretin, even in the wild form, are prone to misfolding, which coupled with decreasing efficiency of the protein quality control system with age may lead to this quote-unquote senile, predominantly cardiac amyloidosis, and there are probably also other conditions. And hence we have these misfolded proteins. You remember they are sticky, they are aggregate, and then we have also recruitment of serum amyloid P component, glycosaminoglycans, and finally we have a final product, fibrils. And at this stage we can see fibrils by electron microscopy. We can detect them with the Congo red stain. But it is important to keep in mind that amyloid toxicity is not just mere displacement and atrophy. It is a true proteotoxicity, which actually begins at the prefibrillar stage. And this perhaps can help us to understand why, for example, some patients who respond very well to treatment with the rapid reduction of the circulating precursors experience clinical improvement, even though the overall load of amyloid has not changed that much. GAGs and SAP are present in all types of amyloid, hence you may come across a term of universal amyloid signature. Clonal plasma cell proliferation is, of course, the underlying feature of immunoglobulin amyloid. But how does immunoglobulin albumin fit into the MGRS spectrum? In order to explain this, I need to introduce the terms of plasma cell neoplasia versus M-component diseases. In the neoplasia multiple myeloma, for example, you have a large tumor mass and you have clinical manifestations due to the clone, bony lesions, hypercalcemia, as well as clinical manifestations due to M protein. Light chain cas nephropathy most commonly, but also hyperviscosity. And yes, about 10 to 15% of patients with light chain amyloid will meet criteria diagnostic of multiple myeloma, plasma cell neoplasia. However, 85% of patients with AL belong to this category. Here, the clone is small, such that there are no clinical manifestation due to clone as such. And patients, if they have detectable M component, they are labeled as having MGUS. However, a subset of these patients develop target organ damage, and this is the 85% of patients with light chain amyloid, significant proportion of patients with light chain deposition disease, and many patients with light chain proximal tubulopathy. And we are talking about small but dangerous clone. You all heard about the peculiar physicochemical properties of these immunoglobulin light chains, which have various acquired mutations, making them unstable, etc. I will not have time to talk about this more. But it is clear that in order to treat plasma cell neoplasia, we need to use clone-targeted therapy. But the same approach is applicable to treat this small but dangerous clone. So immunoglobulin light chain, immunoglobulin amyloid is essentially light chain amyloid, with heavy chain being rare. And still in the developed countries, systemically and in terms of renal involvement, this is the most common type, about 85% of cases. However, amyloidosis overall, we think, is rare. In terms of AL, we make a diagnosis in about 4,000 cases per year. But kidney involvement is very frequent, about 70%, the similar cardiac involvement. However, with cardiac involvement, patients presenting with heart failure and arrhythmias, amyloid doesn't come as readily into differential diagnosis. In contrast with the kidney involvement, patients presenting with proteinuria and nephrotic syndrome have the classic indication for a kidney biopsy, and hence we see amyloid more commonly than our colleagues practicing in other areas. And the differential diagnosis of amyloidosis is really short, and hence amyloid among patients nephrotic patients is not rare. It's at least 10%. Moreover, among patients with MGRS group, light chain amyloidosis is also the most common condition, close to 44%, and this is the relevant reference. For diagnosis of amyloidosis, Congo red stain is still the gold standard. This is recommended by the International Society of Amyloidosis. You need to use polarization, but notice that ISA has revised a little bit recently the requirements, namely the polarization, not only green, but also yellow-green is acceptable, as you can see here. Importantly, keep in mind, please, that some AL may be weakly reactive. Many of us combine Congo red stain with fluorescence. I like Twitzy filter, and that's very useful. It increases tremendously the sensitivity. These are the same areas. Moreover, I want to urge you to consider doing a Congo red stain proactively to rule out amyloid. In particular, if you have seemingly no obvious pathology, minimal change disease, FSGS, sometimes you can see these very pretty, very focal changes, but otherwise this glomerulus looks perfectly normal. So this is the way to go to detect amyloid early. And one word of caution, a small proportion of patients with AL, less than 5%, can have vascular limited deposits in the kidney. Hence, it is important to look beyond the glomeruli. And renal pathologies and amyloid in general, I think that collectively we have the most experience with diagnosis of amyloidosis, and I feel very strongly that we should take the lead in terms of diagnosis of amyloidosis beyond the kidney. And in my department, I look at everybody's Congo red stains. So after we diagnosed amyloid in the kidney, the next question is, what is the amyloid protein type? And here again, light chain derived amyloid is the most common, but it's not 100%, it's about 85%. And it is important to diagnose it correctly because therapies are directed against the clone. The remaining 15% or so is quite a heterogeneous group. There is AA amyloidosis, which is associated with chronic inflammatory conditions, hence here anti-inflammatory drugs are used. In contrast, in ALEC2, there is no specific therapy, hence it is important not to misdiagnose this with AL or AA. And there is also a fourth group of hereditary amyloidosis, which individually given types are rare, including some very rare, but collectively contribute a significant proportion. In the recent study from the Mayo Clinic, based on evaluation of over 16,000 of specimens, rare amyloidosis cases contributed close to 7%. Treatments are markedly different. There is liver transplantation, stabilizers, gene silencers, etc. So it is important to avoid misdiagnosis of these cases as AL, and our goal is to diagnose and distinguish between those which are treatable versus non-treatable and those which have genetic component as well. Now, in the daily practice, if you are using frozen section and immunofluorescence, that works very well for detection of light chain restriction, but do not expect 100% positive reaction. The success rate is roughly about 85% of the cases, and this sort of corresponds also to the recently reported study from the Mayo Clinic. In my practice, if immunofluorescence doesn't work for whatever reason, my go-to method is mass spectrometry. Paraffin immunohistochemistry can be done, but is more challenging. And clinical correlation is important, but it is used to support the diagnosis of amyloid type and guide the treatment, but not to make it. And you have to keep in mind a high prevalence of MGUS among patients with non-AL. So detection of amyloid in the kidney in a patient with MGUS does not mean automatically light chain amyloid. Okay. Now, amyloid deposits are not the only fibrillar type. There is also entity of fibrillary glomerulonephritis, where fibrils are about twice as thick. By definition, Congo red stain is negative, and there is also immunostain for DNA HAB9. Earlier studies reported that, that small percentage of patients, well, actually reasonable, up to 17% of patients may have monoclonal deposits, hence monoclonal fibrillary glomerulonephritis was included in the MGRS classification. However, the situation here is complicating as more stringent criteria are used for examination, including paraffin immunofluorescence, which helps to detect mask deposits. Also, evaluation of IgG subclass restriction has been recently added. Hence, the number of fibrillary GN with monoclonal deposits is probably going to be extremely rare. Please also keep in mind pitfalls that rare fibrillary GN can be even Congo red stain positive. So very careful clinical pathologic correlation is a must, and there will be also more studies forthcoming. And with that, let's move on to crystalline or inclusions category. Now, association between Fanconi syndrome, Benz-Jones proteinuria, and crystals in proximal epithelium was reported in the past as a very rare condition associated with latent form of myeloma, also known as adult Fanconi syndrome. But in 2007, we reported for the first time, this is the reference, also non-crystalline monotypic inclusions in proximal epithelium, and noted that not all are associated with Fanconi syndrome, and therefore introduced a unifying term of light chain proximal tubulopathy. And I am pleased to say that this term actually took off, and it has been used since that time. So LCPT crystalline variant is associated with light chain crystals within proximal tubular epithelium. This can be very focally seen in paraffin sections, but the key diagnostic feature is demonstration of light chain restriction, here shown in the proximal tubules. Typically, kappa light chain, this corresponds to the M component. Clinically, partial or complete Fanconi syndrome. It is rare that less than 5% of this proteinemia related biopsies in the series from Colombia. Beware of the fact that some crystals can be seen as negative images in paraffin sections, and also not all crystals light up by conventional immunofluorescence, and pronase digestion may be needed to confirm. So correlation between electron microscopy, immunofluorescence is very important. By electron microscopy, here is EPON sections, here electron microscopy as such. They can look very pretty. I will not discuss the pathogenesis, but again, unusual physicochemical properties, incomplete proteolysis, and ultimately crystallization. Now, non-crystalline variant. You can see by immunofluorescence, again, light chain restriction, but predominantly lambda light chain. And you can see these sort of small droplets within the proximal tubular epithelium. The same can be seen, confirmed by immune electron microscopy. And in patients who are known to have MGUS at the time of biopsy, this corresponds to their M component. But importantly, some patients were diagnosed with LCPT who were not known to have MGUS prior to biopsy. So this was for the first time detection of the monoclonal component. Non-crystalline deposits are about 3 times more common than crystalline, and here, similar to the situation with crystalline variant, deposits can be masked, and this is reference to the abstract at the last ASN. And then there is even a report of somewhat fibrillary inclusions. So masked inclusions, fibrillary, okay, careful correlation. But what do you see by light microscopy? You may see this peculiar enhanced granularity within the proximal tubular epithelium. We refer to this as a lysosomal overload pattern. It can actually mimic acute tubular necrosis. Yes, there is a tubular damage, and you can also have interstitial infiltrate, hence it can mimic also tubular interstitial nephritis. And there is a renal function impairment, but Fanconi syndrome as such is uncommon. And a related condition is when we have crystals within histiocytes within the kidney, bone marrow, and other organs. This is in the bone marrow, this was in the lungs. We can see this by electron microscopy. Crystals can precipitate also within the capillaries. This is the intravascular inclusions in the kidney, but also similar to LCPT, there is a spectrum, and not all cells show crystals, but this is an example of non-crystalline inclusions, and hence I think that the term immunoglobulin storing histiocytosis is probably more appropriate than crystal storing histiocytosis. And to conclude, interstitial nephritis like pattern of kidney injury. We need to look beyond the glomeruli. We need to investigate a possibility of light chain deposits being focal, extracellular, as well as intracellular, as well as the fact that the infiltrate can be clonal. This image is from Guillermo Herrera's earlier paper. You can see that this looks like interstitial nephritis. These are some relevant references which show how tempting it may be to diagnose interstitial nephritis, but only upon either retrospective review or more rigorous investigations underlying association with MGRS is detected. So before you release the diagnosis of interstitial nephritis and consider any of those differentials, please also consider plasma cell dyscrasia, B-cell lymphoproliferative disorders, when you see image which superficially at least may look like interstitial nephritis. And with that, let me conclude on the role of kidney biopsy in MGRS. In patients with MGUS, to link the kidney disease with the clone responsible for the monoclonal immunoglobulin and hence change from MGUS to MGRS. In patients with no prior history of MGUS, it gives us an opportunity for the discovery of paraprotein-related pathology. And beware of the fact that classification is evolving as our diagnostic precision and treatment options expand. And with that, I thank you.
We would like to thank you so much. And now is the time for questions and answers. If there are no questions on chat, I guess Yola would like to ask the first one.
Yes, we actually do have quite a lot of questions I see in the chat box, and we also got an extra time from the organizers, so don't worry. Our speakers will be able, hopefully, to answer all the questions. But so let me ask 2 quick questions to both speakers. So maybe I start with Dr. Royal. Is there a place for minimal change disease in the classification of MGRS, since we are including diseases that are not directly associated with immune complex deposition, and thinking about maybe cytokine injury or so forth, and we know about the association with minimal change. So I was wondering what's your thought about this?
Well, thank you for the question. I have to say that
Not direct.
I haven't seen any cases of minimal change disease associated with monoclonal immunoglobulin. But I mean, we can speculate that maybe some podocyte toxicity may develop secondary to, as you said, cytokine or due to the monoclonal immunoglobulin itself. But honestly, I haven't seen a case of minimal change disease associated with MIG.
Yeah, I mean, definitely there are papers that show that association, especially with, chronic lymphocytic leukemia, but also with multiple myeloma and MGRS. So it's out there. And I was just wondering, since we are including, other diseases.
Yeah, I guess we are all very much under the impression of the case shown at the last ASN meeting. Yeah, certainly. We need some answers in order to address minimal change disease pathogenesis. So maybe we are in a good shape. There is more to investigate. Yes.
Right. And one more quick question for Professor Picken. You didn't mention amyloid formation in the tubular epithelial cells. That it has been described as, tubular amyloid tubulopathy,
Yeah.
and the other one when the casts, otherwise normal light chain casts, are present, and there is amyloid formation on the surface on these casts.
Yeah, certainly. There are at least two very elegant publications. One, I think, from Nadasdy's group, the other one, Chris Larsen published, beautiful images, beautiful Congo red stain. I didn't show images during this presentation. It's certainly something to consider. Intracellular amyloid deposits can be seen in the adrenal gland, so some of these Congo red staining inclusions may show fibrillary ultrastructures. So there is definitely a spectrum and a range. With regard to the intratubular casts, which on occasion can show Congo red stain positivity, that's what I assume you are referring to. Yes, there are studies which show that if you see that there is increased likelihood of finding amyloid elsewhere in the body. So it's something definitely to look around. And I think that similar to other examples of MGRS in terms of amyloidogenesis, we have these different stages, prefibrillar deposits, fibrillar deposits. So yes, there are certainly options. If I may also digress, I saw that Cynthia Nast has sent on the chat a comment that immunostains can be helpful in demonstrating light chain restriction in the proximal tubules. Absolutely. I didn't have time to elaborate on that, but whatever works is good. And pronase digestion I mentioned, but in some cases, immunostain may work fairly well, but not so much. I am not particularly fond of using immunostains on paraffin sections with amyloid. That's my sort of bias.
Okay. Professor Malyszko, do you have questions, or we can go through the questions from the box?
Just one question. Do we have any data or any idea how frequent is recurrence in the graft of MGRS and how early it can recur? I'm fully aware that we have not so many biopsies, that we have donated kidneys and grafted kidneys, but do we have any hint of a data, how frequent it is and how early it is?
Virginie, do you want to take it?
Well, yeah. Well, yes, there are some literature on this question. already published. And what we know is that the recurrence rate is very high. I think it's somewhere about 80% of the cases, and it tends to recur quite early after the transplantation.
Mm-hmm.
I don't know if you want to say anything, Maria?
Yeah, in my experience, I sort of remember a case of a young woman who was labeled with interstitial nephritis, sort of chronic stage. She underwent transplantation. The first post-transplant biopsy shows sort of was processed only for paraffin, you know, I don't know, maybe mild rejection, but within couple of months, she had a recurrence of light chain proximal tubulopathy. So it can be very, very swift. It may not be detected if early enough, if the transplant biopsies are just processed for paraffin, and there is this truncated workup protocol, paraffin sections, C4D stain, no further studies. Next case, please. So we may be losing some of those earlier recurrences, but I think a big part of it is raising awareness. So if you have a patient who is known to have MGRS, I think the recommendation is to make sure that this is taken care of before the transplantation, or if it is discovered after transplantation, close follow-up is needed.
Yes, because I think the real issue here is that some of these patients are not recognized as such. Well, the diagnosis of MGRS-related lesion is missed on the native kidney biopsy, and those patients tend to recur very, very early and to lose the kidney. When they are diagnosed as MGRS associated, and these patients should be treated before they get the transplantation, and those should, in fact, have a better outcome.
Yeah.
And that's why I'm asking, because if there is the graft is lost due to the recurrent of MGRS, so that's why we need to very, very carefully evaluate potential kidney transplant recipient for the second graft. So it's one point. And the second one, because MGRS is like no one disease. It's not a disease well, exactly, because we do diagnose the MGRS with the help of pathologists. However, we are not able, at least in Poland, to treat MGRS. So that's why we have to ask hematologists. So the problem, our problem is what to do when the graft is lost. So we do have to treat before the second graft and before the evaluation. So that's why, as Maria told, that the most important part is to raise awareness. So maybe we will find some solutions in their interdisciplinary team to enable people to get the second graft and to have the better prognosis for the first one.
And awareness and convincing the hematologist that it does matter, because ultimately there is a loss of graft. So either you give immunosuppressive therapy before the transplant, or you lose the graft and you still end up giving immunosuppressive therapy for transplantation. So, yeah.
And it's also the crucial point is to find a clone, if whether it's a B clone or non-B clone, because this is really the matter of the treatment. We can offer.
Yes, absolutely. Yeah, if I may comment, I mean, when I showed the slide about monoclonal fibrillary GN, I don't want people to come with the feeling that we are discarding this entity. It's just that it's becoming very complex. As more stringent criteria are being used, different techniques, etc., the overall incidence of clonality in this patient group is changing, but we have to keep in mind that these entities have emerged relatively recently, and relatively recently they have been evaluated with these extended technologies. So nothing is written in stone, and even in the latest publication, Sami Nasser said, sort of referred to one of the cases which were previously earlier diagnosed as monoclonal fibrillary. They reclassified it based on the newer technologies. So it's a work in progress, as Virginie said in her presentation. Thank you.
Thank you. And we'll have some questions from the audience. So let's start in order received. I guess the question for Dr. Royal. Can the deposits be focal, segmental, and variable granular, or need to be diffuse in the setting of proven monoclonal protein by urine and serum electrophoresis?
I would say it really depends on the diagnosis, on the specific disease. In the case of MIDD or PGN-MID, I would expect the deposits to be diffuse. However, in some cases of cryo-GN, the deposits are focal and segmental, but it really depends on the diagnosis, I find.
Mm-hmm. If I may continue, I think I agree, but maybe rather than the type of diagnosis, maybe the stage at which the biopsy is evaluated, because I don't know, you may recall Guillermo Herrera several years ago, cases with the interstitial tubular basement membrane limited monoclonal immunoglobulin deposition disease, and he was postulating that it could be very limited to interstitium. And then more recently, there was a paper from the French group essentially describing monoclonal immunoglobulin deposition disease, which was centered on the interstitium with seemingly sparing of glomeruli and hence without proteinuria. So as you said earlier, the spectrum is very wide. So I think it is probably not possible to make generalized statements that you knew this, that, or that. It's sort of some kind of guidelines rather than definitive criteria at this point. That's my take.
Second question to Dr. Royal. How often does one have to obtain mass spectrometric data to make a definite identification of the protein present in deposits?
Well, again, it depends on the disease. More frequently in amyloidosis, and I will give the floor to Maria, but you also know that in some exceptional cases, mass spec can also be useful to determine the type of deposits that are involved. We described a case of MIDD caused by an IgD heavy chain, which was demonstrated by mass spec. But again, this is an exceptional case. But in the case of amyloidosis, maybe Maria, you can answer the question.
Yeah, I think in the US, there is a very strong bias to use mass spectrometry for amyloid typing. I think maybe that's sort of more true outside of renal pathology. In renal pathology, you may have noticed that the European colleagues presented immunohistochemistry in paraffin sections, which is used pretty much throughout the European centers. But this, in contrast, in North America, at least in the US, we still like to use frozen sections. And I think that with frozen sections, we have a better shot at successfully typing light chain derived deposits in a significant proportion of cases, because ultimately what we are doing is we want to recognize light chain amyloid versus everything else, right? And then with everything else, we can use other techniques. And application of frozen sections gives us advantage because we don't have to deal with the background stain. We are essentially testing for proteins which are in the deposits, but they are also present in the circulation. So the tissue has a background, and this can be very tricky. And I think there are very reputable laboratories which do great and successful immunohistochemistry in paraffin sections, but caution and experience is really very important. In my practice, I use frozen sections, immunofluorescence. About 85% of the light chain cases, I feel comfortable, confident that I have a good support for the diagnosis of AL. But in the remaining cases, and in particular outside of the kidney, if I don't have frozen tissue, mass spec is my go-to method.
Great, thank you. So we have another question, again for Virginie. Did you have any membranous GNs with IgM kappa deposition and positive PLA2R?
No, I haven't. And in fact, all the membranous, the monoclonal membranous nephropathy that I've seen were IgG. As were all the 28 cases from the Arcana series that was published in 2017. First, so I would say that, I mean, it would be a bit exceptional to have an IgM. I'm not saying that it's not possible. It's still something that, I mean, could be explored, but I think the clinical correlation in this case would be very important. And the other thing is you have to remember that from the series from Arcana, they identified 3 features that were associated with an underlying lymphoproliferative disorder. And one of these 3 features was the negativity of PLA2R. So yes, I would say that the positivity of PLA2R goes maybe a little bit against the association with a monoclonal immunoglobulin, but I mean, I think that in that kind of case, you have to really go with the correlation with the clinical information.
Yes, maybe this case would require, IF on paraffin embedded tissue after antigen retrieval, and maybe they could discover that they are IgG then somewhere. That's a possibility. We also have a comment from Dr. Hopper on MIDD, and he's saying that yes, nodular glomerulosclerosis is seen approximately in 50% of cases. So I guess that's kind of a warning. It's not all not all light chain deposition diseases will have nodular pattern, right?
Absolutely, and the nodules are more frequent in HCDD. MIDD related to a heavy chain. That's the first thing. And the second thing is that, as Maria mentioned earlier, there are cases that are exclusively tubulointerstitial with no glomerular involvement and no proteinuria. So I agree with Dr. Hopper on that.
And one more question to Dr. Royal. Have you seen PGN-MIDs with diffuse crescents?
I haven't. Again, it doesn't mean that it doesn't exist, but I mean, the cases that I've seen had focal crescents. So I would say that it would be unusual to have diffuse crescents, but I mean, as you know, everything is possible, but let's say that it would be an exceptional case.
So one more question. When do you start using immunochemistry, immunofluorescence, or in situ hybridization for kappa and lambda?
For whom is this, Virginie or me?
For Virginie, for Dr. Royal.
Yeah.
I'm sorry, what's the question? When do I start using IF?
immunofluorescence or in situ hybridization for kappa and lambda?
Well, I do use IF regularly on all kidney biopsies. Immunohistochemistry, I use it, well, as we discussed earlier, in some specific cases when IF fails to identify the involved light chain. IHC can be used to demonstrate, as we said, the intracytoplasmic crystalline inclusions. Sometimes also casts can sometimes be, the light chain involved can be demonstrated in some casts. I don't use in situ hybridation because, I mean, you have to have a cell to use it.
Exactly. Yeah.
And, extracellular deposits, so that's why I don't use it.
Yeah, I guess in situ hybridization is useful if you want to determine whether you have clonal infiltrate and hence, you know, cells, but not the deposits. Yeah.
Okay, Maria, question for you.
Finally. Yeah.
It's about treatment. What do you think about adding doxycycline to the treatment?
Yes. Okay. Yeah. All right. I got nailed on this by cardiologists. Do you want the official status or unofficial? Well, no, I'm serious. So there are established treatments, and there are many, and they are changing all the time. But cardiologists like to add doxycycline to not only transthyretin amyloid, but also to light chain amyloid. And they think they sort of support its addition to the established chemotherapy as a sort of helpful additional supplemental treatment. So doxycycline not as the primary line, but as additional. And there is actually a recent article published not long time ago, maybe last month or so, where there was some first more rigorous comparison head-to-head with a number of patients, not too big, but nevertheless comparisons. So don't go with doxycycline as the only or a primary treatment, but yes, there are those who clinicians like to add it, in particular for patients with cardiac involvement. I haven't heard this being advocated for patients with renal involvement so much, but with cardiac involvement, it is said to have some additional positive effect. And it is, you know, easier to get. And you may actually hear this business of repurposing of older drugs for new treatments. And for example, diflunisal, which is an NSAID drug, which has been on the market for a long time in the US, long time approved, and about to go off the market, has been tested for treatment of transthyretin amyloidosis. So I think, you know, we are living in the time where people are looking around. The spectrum of diseases is expanding, new treatments are becoming available, and the balance is very fine. What does it matter? When does it matter? And things like that. So thank you for the question.
Thank you so much. Thank you so much, dear moderators, distinguished lecturers. We have to move on. And let me introduce Cynthia Nast, who is going to announce the posters that we decided that deserve to be rewarded at this edition of 4th IRPC. Cindy?
Yeah, can you hear me?
Yes.
Yeah.
Okay, just checking. So there were many interesting and educational posters, and I encourage everyone to view the posters, which can be found if you go to the conference homepage and scroll down below the organizing committee members, and you'll see the poster sessions there. And if you click on that, you can see all the posters. And for the purpose of deciding winners, we've divided the posters into case reports and clinical or translational research posters. And one winner was selected from each of these two categories. And the winners will receive a certificate and a cash award. The case report topics were quite broad. They range from crystal storing histiocytosis to infantile kidney AV malformation, childhood atypical anti-GBM disease, transplant kidney with either collapsing glomerulopathy or renal cell carcinoma, and collapsing glomerulopathy in a patient with undiagnosed sickle cell trait and possible alpha thalassemia, as well as others. The winner in this category is Dr. Zalewski from the Department of Medical Pathomorphology at the Medical University of Białystok in Białystok, Poland, for his poster titled Novel Splice Site Variant of FAN1 Associated with Karyomegalic Interstitial Nephritis. As we heard in a talk earlier today given by Dr. Ammon, karyomegalic interstitial nephritis is associated with mutations in the FAN1 gene. In this poster, Dr. Zalewski and colleagues described karyomegalic interstitial nephritis in a patient with a family history of renal disease. Following the biopsy diagnosis, they did an analysis of the FAN1 gene in the patient and family members. The patient's mother was found to be a carrier of an exon 12 deletion, which is known to be associated with karyomegalic interstitial nephritis. And the patient had this exon 12 deletion, but also had a splice site substitution at intron 8. And this was a compound heterozygote, resulting in the clinical expression of this autosomal recessive disease. And the splice variant has not been previously reported in karyomegalic interstitial nephritis. So we congratulate Dr. Zalewski on being the winner of the case report poster. For the research posters, this included a broad spectrum of clinical and translational studies, and these included such things as kidney findings in an autopsy series of COVID-19, diffuse mesangial sclerosis, expression of dendrin, CTGF, and c-MYB as early markers of chronic renal disease, CD163 macrophages in ANCA-associated vasculitis renal disease, the course of PLA2R membranous nephropathy, and transplant biopsy microRNA expression in antibody-mediated rejection versus ATN. These are all, these and more, very interesting posters, and I strongly recommend you go look at them. The winner in this category is Dr. Stayland from the Department of Pathology at Haukeland University Hospital in Bergen, Norway, for her poster titled Renal Polyvinyl pyrrolidone deposition in drug-addicted patients. In this study, Dr. Stayland and colleagues evaluated the morphologic changes in kidney biopsies from patients who were injected opioid substitution drugs. These drugs contain this PVP, which is a water-soluble, high molecular weight polymer that is not metabolized and not filtered by the kidney. So this PVP was associated with vacuolated interstitial macrophages, tubular cells, and glomerular mesangial and endothelial cells, but not in podocytes. This was associated with severe tubular interstitial scarring and elevated serum creatinine levels. And the authors propose a definition for identifying these vacuoles that contain PVP as opposed to other vacuoles such as lipid vacuoles. And so this was a novel contribution in actually defining what these vacuoles look like and being able to differentiate them from other vacuoles. So congratulations to Dr. Stayland. I would like to let the winners know that I will be emailing you to get your contact information so we can send you the certificates and the cash awards. And again, congratulations to the winners. And I encourage everyone to look at the posters before the end of the meeting. And hopefully, I think they'll be available after the meeting as well. Is that correct, Agnieszka?
Thank you so much. Thank you so much, Cindy. So I think that it is a time to finish today's sessions, and I hope that we shall see you tomorrow. Tomorrow is the last day of the 4th ERCP. Thank you all. Thank you so much. See you tomorrow.